to welcome you all to another opportunity for a conversation on the leadership role primary care plays in the emerging NHS. I'm Mohit Venkatram. I'm an Executive Director at East London Foundation Trust. When East London Foundation Trust decided to step into the primary care arena, there was recognition that we were working with some of the most hardworking, dedicated GPs, nurses, and other professionals. While we were not the experts in delivering primary care, the resources we brought as a large statutory body allowed us to join forces and deliver outstanding services to our local residents. This journey led us as organizations to develop many opportunities of learning, QI, and support functions. The webinar series is one such development where together we explore the themes that allow us to improve care. Primary care has always been a source of inspiration to me. In August this year, we had 314 fewer GPs in the country than we had in August last year. Despite this, 26.5 million appointments were delivered by general practice alone in this country. There are a lot of views about how long people are having to wait for an appointment. So I looked up the data. In August, almost half of the appointments were delivered on the day of booking itself. 48% of these appointments were done by GPs themselves. Our conversation today is recognizing the role we have together as society in equity and equality. Many of us actively participated in the pay and gender equality battle. The theme for discussion today is about health and gender equality. Over the last few months, the conversation on the impact menopause has had on our female colleagues has awakened the need to develop targeted approach that supports equity in society. It is absolutely essential that women are comfortable talking about their health, have access to health that is needed, have the right information that should be there, and are supported to achieve the full potential that allows us as a society to stand tall. Who better to guide this conversation than the very first Women's Ambassador in England, Dame Leslie Regan. As well as being a professor of gynecology who has achieved academic eminence, she is now spearheading the implementation of the upcoming Women's Health Strategy for England. Leslie, welcome to the show, and thank you so much for your time today.
Thank you very much.
Before I hand over to Leslie, a reminder to all our phenomenal participants. There are almost 400 of you who have registered for the event today, and the numbers are climbing. So may I just remind you, please use the Q&A section to post any questions you may have, and we will then pull out the themes from them, from the common questions, so we can respond to it. I'll with that hand over to Leslie. Leslie, over to you. Thanks again for coming.
Thank you very much indeed for inviting me. It's a real pleasure to be here. I'm going to share a few slides with you. I promise you I'm not going to kill you with PowerPoint, but just a few, just to sort of set the scene. And it gives me a prompt to remember to thank some of the various people that who've been involved in getting us to this point. So I'm sharing my screen there, and I'm just going to start there. Mohit, can you see my slides? Yes?
We can. Thank you.
Well, thank you. So you've already introduced me most generously. Thank you very much. The other thing I should say is that I'm chair of the charity Wellbeing of Women, and I'm so glad that that charity has now really tried to champion all of the strategic plans and aims that the Women's Health Strategy for England is setting out to deliver. So I want to base all this around talking to you about something it's very obvious to you as general practitioners and working in primary care, is that women's health is about a life course approach. It really is cradle to grave. And although I don't tend to deal with the very small children from the age of about 11 onwards, girls and then younger and older women come under my remit. And I think it's an enormous privilege that one's able to look after women across those life spans, because what I've come to realize very, very clearly is that her health in each of her decades of her life impacts positively or negatively on the next. Now, I'm a bit ancient now. I've been a gynecologist, I'll confess, for just over 40 years. So my generation, I think, were trained to work in what we had was a disease intervention service primarily. And this, I think, is the traditional view of what we thought women's health needs were. We broadly divided them up into childhood or adolescence, the reproductive years and the post-reproductive years. And for the most part, with a few minor exceptions, a few screening exceptions, we've sort of waited for them to turn up with a problem in one of those three age brackets. But what I'd like to emphasize today is that what I really hope that we're going to be able to demonstrate using this women's health strategy is that you and I know we can actually predict women's healthcare needs from cradle to grave. And if you look at this chart, you will see how very important things like menstrual health, periods are, how incredibly important contraception is, not just for preventing pregnancies, but for helping to control menstrual problems, pelvic pain, being an adjunct to HRT in later years. And if we look over to the right-hand side of the slide, we'll see the menopause. Now, that used to stop sort of at 50, and women sort of disappeared from the view of the health services, in my experience, until very recently. And I suspect that's partly because I, as a menopausal woman now in my 60s, recognize that I'm probably going to live just as long post-reproductively as I was reproductive. And so, although as I tell anyone who will listen to me about this, I'm not planning to live forever, I do want to live as well as I possibly can for the years I've got. And I think it's really very interesting as well. If we just reflect on the middle part of this graph, you'll see now that only 4 out of 5 women, or 80% of women, are going to have pregnancies. Not every woman's going to have one now. And actually, it's a relatively short span in a woman's life being pregnant, and all the other issues about her health, so much of which is preventable and so much of which is predictable, are so crucially important. Now, I'm going to make the argument that we've underfunded women's health for decades, and there are all sorts of complex political and sociological reasons for that. But in broad terms, the NHS spends over 100 billion treating disease and only about 8 billion on prevention. And because, as I'm going to go on to show you, we've been particularly disadvantaged, I think, in women's health because of the siloed commissioning that's occurred, women really have fallen through the cracks. So this is a quick snapshot, and you may be a bit surprised by some of these things, or others of you that are gurus in this area will not be surprised at all. So we are the most obese nation in Europe. And despite that fact, we know that 1 in 4 mothers are overweight or obese at least. We know that 1 in 5 mothers are still smoking during pregnancy. We know that sexually transmitted infections are rising, mostly amongst younger women. And when you ask them why they haven't got help, they say that they can't access help. And perhaps most importantly, contraception is increasingly difficult to access. Now, how can that possibly be in a country that's really the envy of many other countries in the world, where we have an NHS free at the point of delivery? Because the access to contraception has proven to be so increasingly difficult, we now have an unplanned pregnancy rate of 45%. We have a teenage pregnancy rate that's highest in Europe. I must pay tribute here to Alison Hadley and her teenage pregnancy team and their cross-departmental thrust over the last decade to reduce the rate has done wonders, but it's still the highest in Europe. And we have an abortion rate which is rising, but only in older women, 35 to 45-year-olds. And when you ask them why it is that they're needing to request an abortion, they're telling us that they've completed their families and they can't access long-acting reversible contraception. So I think that's a little bit of a failure on our part, and I'm taking responsibility for it. Now, you add to that all sorts of other things that you as primary care practitioners are going to be looking after on a daily basis. We know that maternal mortality is 4 times higher in Black women than white women. It's twice as high in Asian women compared to white women. We know that at least 15% of women have a degree or other of postnatal depression, and there are a vast majority of mental health problems. We know that women behave differently with the various types of dementia. We know that 1 in 4 of our workforce are menopausal, and many of those women are leaving the workplace because they feel unable to continue because they can't have time off or particular preferences given to their working environment. And a topic that still remains completely taboo, and that's urinary incontinence. It affects 1 in 3 women over the age of 60. And I think one of the reasons why we've found that women's health have been so affected disproportionately is due to these public health funding cuts that came in 2014 following the Health and Social Care Bill of 2012. And there's an enormous amount that I could go on to detail you about this, but I'm not going to. I'm going to turn my thoughts to being very positive and how we can improve things for the future. So why do we need a women's health strategy? Well, this was an argument I had when I was president of the Royal College of ONG, and I badgered every politician who I could possibly corner in a room about this. We are 51% of the UK's population, 47% of the workforce. We undertake the vast majority of unpaid caring roles, but not receiving the attention that women deserve. And perhaps most importantly, enormous variations in access and quality of services across the country. And what we can honestly conclude is that women are experiencing health inequalities and outcomes that could really be very easily avoided. And it's not rocket science, any of this, and it's not even that expensive. It just needs to be sensibly reorganized. Now, I'm just going to share with you a couple of influential women's health publications. Well, I've been involved with them, so I suppose I would do, and you can tell me I'm biased. But the first, of course, and the one that really opened my eyes to this was Sally Davis's CMO report of 2014, when she decided to turn her lens, her forensic lens, on the health of the 51% women. And what she advocated in that is that we were missing opportunities all the time to help women in their reproductive years and in their post-reproductive years. And during my time as president at the RCOG, I worked with my colleagues there, and we published in December 2019, just before we all went into lockdown, the Better for Women report. And this was to improve the health and well-being of girls and women and our first recommendation and primary aim was to create an NHS-led women's health strategy. And you'll see on the right of this slide, the categories that we looked at. Instead of looking at individual disorders or diseases, we based everything on a life course approach. And then we looked at how women can access accurate education and information, and how we can prevent problems occurring, and how we can empower women to be part of that prevention. And then we took a very critical look at the fragmentation and the very, very difficult access to services that are developed because of that political history that I've briefly alluded to. And then there's one other publication that I think you might find interesting, and I'm happy to send you a PDF if you send me an email address, is the Commission on Status of Women. It was launched at the UN in March of this year. And here I am with Claire Gerada talking about the women's health agenda and how we redress the balance. And once again, these topics came up: contraception, abortion, assisted conception, menstruation, menopause, breast cancer, cervical cancer, all these really, really common things that we're doing so badly and are really, undermining the status of women in society, not just in the UK or in the US, but globally. So this is the call for evidence and the case for change, and I'm really very grateful to the UK government, whichever government we've got this evening, to have championed the idea that we should have a call for evidence and change, and that we should develop a women's health strategy. It was brave, and I think particularly brave because although they launched the call for evidence on the 8th of March 2021, the 8th of March, of course, being International Women's Day for the cognoscenti amongst you, they had the call open for about 14 weeks. And I think it's fair to say that everybody at the DHSC was somewhat shocked by the deluge of responses. They received over 100,000 responses from the public. And what their aim was to do was to improve the way in which health and care system listens to women. And they also wanted to improve women's health outcomes. And of course, try and tackle some of those huge disparities in outcomes across the different groups. And this is how they approached the survey. And my thanks to the Women's Health Strategy team at the DHSC, who've done an enormous amount of work to pull all this together and collate 100,000 submissions from the public and then 400 written and very detailed submissions from healthcare professionals and organisations. So they ran a survey. They had an open call, as I've just said to you, and then they also ran some important focus groups, particularly with women from underrepresented groups across England. And this was led by the University of York and also by the King's Fund. So this is a quick snapshot of the results from that call. Certainly, there was no doubt amongst the 100,000 individuals, 98% of whom were women, who responded to what they wanted to talk about and what they wanted help with: gynae conditions, fertility, pregnancy, the menopause, menstrual health, mental health. Many of them said, 84% in fact, that they were not being listened to by the healthcare professionals that they'd spoken to. They weren't being given the opportunity to ask questions. They felt they'd been dismissed. 2/3 of the women who were in the workplace said that a health condition or a disability had impacted their life there adversely, and they wanted to be able to talk about these things openly at work and to get flexible working arrangements if necessary, and to be able to access occupational health services. And less than 10% of women in that 100,000 said that they had enough information on these really common things like menopause and menstrual problems and common gynecological conditions. And they said that they were more likely to rely on their family and friends and Google for health information than they were in going to us healthcare professionals or the NHS website. So, as Mohit was saying, earlier this summer, we published the first ever Women's Health Strategy for England, and I very much hope that it marks a reset, an immovable reset, actually, in the way in which the government's looking at women's health. And it's a very aspirational and ambitious strategy, setting out 10 years' worth of plans for boosting the health and well-being of women and girls, and for improving how the health and care system engages and listens to them. So I think it's important to say that this listening is an ongoing issue, as opposed to we've listened and we've done it. We need to continue doing the listening. And it certainly builds on the vision that was published in December 2021 that I just mentioned to you. Now, the strategy does adopt the life course approach to women's health, and this is a slightly different diagram looking essentially like that predictable needs. Once again, we're picking up that we understand that there are changing health and care needs of women and girls across their lives, and trying to identify the critical stages and the transitions, and to prevent negative health outcomes and to promote health and well-being, not just to focus on disease intervention. And these are the main cross-cutting themes in the strategy set out in the report: women's voices, information and awareness, access to services, disparities in health outcomes between different groups of women. Health in the workplace has taken on an enormous interest recently, particularly with the menopause campaigns that many of you may have been involved in recently. Education and training for health and care professionals, research and evidence, and of course, data and digital. Now, I obviously can't go through all of those, but I'm just going to pick a couple of things before I finish and welcome your questions. These are the 7 priority areas. I think we started off with 5 or 6, but we've got now a 7. Menstrual health and gynecological problems were right at the top of the list. They were the ones that most women wanted more help with. And I think it's really important to remember when we talk about menstrual health, This is something that's been very difficult to talk about until relatively recently, and may still be for some women very difficult to talk about. But this is an event that occurs about 12 times a year for 40 years of a woman's life. So this has to be part of the normal everyday things that we talk about, and that we as healthcare practitioners, when we're seeing a woman for whatever reason, need to inquire about, just to make sure we can optimize it or alleviate problems. Get her back into education, or get her back into the workplace or into a caring role. And then you will see, you can read the slide as well as I do. There was fertility and pregnancy, menopause, mental health and well-being, cancers, the health impacts of violence against women and girls, and that's going to take an enormous amount of energy and effort, I think, across many government departments. It certainly won't be just the Department of Health and Social Care that works on that. And then healthy aging and long-term conditions. And as we become an older society, we can expect women to be living longer and longer. But at this moment in time, women live longer than men, but they spend significantly longer in poorer health. And I think that's what we can aim to change, you and I. So why does this access to service matter? Well, in the call for evidence, we repeatedly were told about how difficult it was to get high quality information and advice on how you get, for example, accessing the right form of contraception. And yet contraception, we know, is the single most cost-effective intervention in healthcare. Fact. The return on investment surpasses any other thing in healthcare. So it is crazy that we don't make it really, really easy for women to access it. Not just, as I said earlier, for preventing pregnancies when they don't want them, but also for managing menstrual problems, managing pain, and also being helpful in the management of menopausal symptoms for some women. So, a spotlight on the access to services. The strategy sets out our ambitions that we want women and girls to be able to access services, access them that meet their needs across the entire span of their life, from adolescence through to the post-reproductive years. And we want to also have the ambition of having a system-wide approach to women's health based on their reproductive well-being, their individual choice. And that means that we've got to really reflect the life course, as I was saying earlier, rather than organising things around a particular health condition or the needs of commissioners, which has definitely been the issue, I think you will agree with me, with contraception in the past. It was commissioned in 3 separate silos, and none of those silos picked up the tab when they didn't do it very well. So there's not much incentive to get it right. And I think very importantly, what we heard loud and clear, in fact, they were shouting it, that women and girls want to have their healthcare needs met at one time and in one place. Perhaps not every single thing the same day, but very much more cohesion and wrapping the services around them, rather than making that woman go around 4 or 5 different hospital or clinic or GP surgery appointments, trying to access things and constantly being told, no, you can't have that because we don't have the budget for that. If you look at the report, you'll see some interesting case studies of best practice. And the Women's Health Strategy team and I have done a bit of travelling over the last couple of months, whilst the political hoo-ha has been ongoing. We've done a bit of travelling. And we went up to Liverpool to look at their health hubs, which is a very interesting model between the commissioners and the primary care trusts up there. We went to Manchester and to a community gynecology hospital in Wythenshawe, which is a totally different model. And then we've talked more recently about the pilot study that my team at Imperial College, where I'm clinically based for 1 or 2 days a week, has piloted the introduction of post-delivery contraception, so that all women delivering babies in those Imperial Hospital hubs goes home with a year's worth of contraception. And it has a massive return on investment. That's not just you spend £1 and you save 9, you save about 16 or possibly even 20. So this spotlight on access to services, I think, has hit home with an awful lot of women, and also a lot of clinicians and other healthcare professionals that I've been speaking to in the last few months. So the strategy is committing to encouraging the expansion of women's health hubs, contraception in maternity settings, for example, and any other model of best practice. We're welcoming and encouraging people to tell us about what they think their best practice is, and we can adopt it. spreading best practice, including supporting the NIHR funded evaluation of the existing women's health hubs, which I hope we're going to have the summary and the readout by about March of next year, and highlighting existing resources such as the Primary Care Women's Health Forum and the Women's Health Hubs Toolkit. We're also establishing a women's health accreditation programme to recognise commissioners and providers who offer services in this way and promoting best practice across the country. I'm really keen that we show people what good looks like and then encourage them that they're not that far away, and with a bit of jiggling, we could get there too. And we're also going to commission a reproductive health experiences survey every couple of years, beginning this year, to gather data on women's experiences of reproductive health to inform local and national decision making. So I always feel rather embarrassed about this, but the man who made the video kept saying he thought he would beamed me up Scotty. So I'll just show you.
Throughout my career as an obstetrician and gynecologist, I've constantly met women telling me that they haven't been listened to about the problems that they want help with. Today is a very exciting day. It's the launch of the first ever women's health strategy in England. I think the significance of this document is it's the first time that we've ever thought about women's healthcare holistically, in the round, putting women at the centre and wrapping what they need around them. I think that listening to women is really crucial. I think tackling the disparities in healthcare that occur across the country, regionally and across socioeconomic and education groups is crucial too. And I think there's so much that we can do to make simple services easily available to women. I'd like to say to all of the women that responded to the public consultation, thank you for taking the time and trouble to share your thoughts and make your suggestions. We have listened. This is the first of strategy documents helping us to start off and launch this new way of working. And we will continue to listen to women, and we will continue to change as we implement all the things that we need to do to improve care for women in England.
So I'll leave you with that. I'm a great believer that it's not just women that benefit when you get their health right. When you get it better for women, you get it better for everyone in society, because they're very good at spreading the word women. So I'm hoping that effectively what's happening is by having a women's health ambassador, we're going to get 51% of the population to come and be ambassadors with me, and then we'll really be able to get it right. Thank you, Mohit, for listening.
How fascinating. The drive and nudge you bring to this is phenomenal. It's such a delight to hear this. And it's such a crucial part of it. I think the last few words you said about if you get it right for women, you get it right for everyone. Society rings true. It rings true in so many ways over generations. It's shown that. As you would expect, the Q&A is abuzz with thoughts and views for people. So let me pull the first one. It was a phenomenally important question. And there's a lot that depends, that's riding on the mental health during perinatal, postpartum stages of life. But not often is there a conversation about mental health support during the reproductive phase, the reproductive mental health for women, which is more around the full lifespan of a reproductive. And some thoughts on that, Leslie. What do you think can be done about that?
Well, I'm ashamed of the fact that in the last maternal mortality report in this country, one of the highest avoidable causes of maternal death was suicide, and that every one of those suicides recorded was known to mental health services. So I have to conclude that we failed them, because we know that pregnancy can be very stressful if you have mental health instability. And we know that many women develop a degree of depression either during their pregnancy or most usually postpartum or in the first year of life. So we also know that although much money has gone into perinatal mental health services, it's actually seems to be just tackling the tip of the pyramid, or the top of the bit shining, sticking up over the surface of the water, and that underneath the surface there are many more women in the perinatal era who have got mental instability and mental health problems, which if we could identify and help them with, we would prevent them getting much more worse. So the point where you get women who've become psychotic is fortunately rare, but they always start with much lesser problems, and we've got to be much better at talking about them and helping them.
Thank you. And you're absolutely spot on there when you talk about widening the access that's made available to people. And I think from the widening access comes the pertinent question, the role primary care plays in this, because primary care is probably the mouth of all the health services. It is the one place where people can access care and information much quicker. But interestingly, many of the supports that are available for women, even IUD, long-term bleedings, are only accessible in secondary care quite often. And given the new strategy that's coming on, how do you think we can change this around so that both the workforce, the skills, and the resources are available in primary care, so it widens the access to what's available, which is exactly where your report started from?
Yes. Well, I think we've got to be very brave, and we've got to start repositioning the deck chairs around the Titanic, haven't we? Because there is a lot of money in the system, and I'm a realist here, and I know that there's no more money to go into this. So we've got to try and ensure that every pound is spent wisely. And at the moment, taking contraception that you just mentioned as an example, women can go to 3 or 4 different doctor's appointments and be told they can't have something, as opposed to, oh, yes, you can. So, Mohit, you know, your wife or your daughter could come and see me because I'm in a secondary care specialist menstrual disorders clinic, and I could give her a Mirena coil and sort out her periods and make sure that she doesn't need to do anything further about them for the 5 years duration of that coil's life. If she walked in and said, "Ooh, Professor Regan, could I have some contraception?" I meant to say no. I confess that I probably wouldn't, I just put it in, but I meant to say no. And while she's undressed and I'm fitting that coil for her, which is not the nicest thing that's happened to her that week, I'm not allowed to do her cervical smear, and I'm certainly not allowed to book her for a mammogram. I mean, this is madness. And it, as I said right at the beginning, none of what I'm talking about is rocket science. And we don't need doctors to be doing this either. We can have all sorts of healthcare professionals who can contribute to this. And I'm not trying to offset tasks. I'm just trying to say, let's get hubs together wherever they are. They don't even have to be physical hubs. They could be actual virtual hubs to triage girls and women, find out what they need, and then we can have a more limited number of physical places where they go to have, for example, procedures done.
I think that brought such a smile to my face, because our processes sometimes come in the way of our aspirations to support people to widen the access. We constrain ourselves from what can genuinely be the right way for society to approach something.
Yes.
And Leslie, what does strike is, though it's a women's health strategy, the term women itself in today's world doesn't quite signify the number of people who require support from these services, because people are gender fluid, who may have at birth had the female sex, gender. It depends on how they want it. There are different genders who now ascribe to having the same issues. How far do you think the strategy and the development of the strategy goes to address the wider society that requires the same support, but fall within the 51% not labeled only as women?
Well, I'm conscious of the fact that I'm stepping on volcanoes or rocks or torpedo, whatever the right analogy is. It's been a long day today, but I've always been very straightforward and simple about this. I've been working as a gynecologist for over 40 years, and I have seen almost every type of person of any sort of description of gender. And I've always reckoned that if they walk through the door, figuratively speaking, or virtually, or they're on my video platform with me and they need my help, I will look after them. So I'm afraid I don't subscribe to changing all of the language. I don't subscribe to getting rid of the word women. And this may get me into a lot of trouble, but I think that it's the name for 51% of the population. And I am very inclusive of anybody who doesn't fit themselves into that description. But I don't think we should be changing all of the terminology overnight like that. I really do think that we can be inclusive and ensure that women who are transgender or whatever you want to call it, they can all have services that they need. Of course, they're going to need cervical screening. Of course, they're going to need problems with help with their periods, et cetera, et cetera, et cetera. And I think that what we're proposing here is a strategy that is inclusive for anyone that needs these services.
Fabulous. I think that captures the sentiment with what people are asking the question, because the language in itself becomes slightly meaningless as long as the support is available to everyone who requires that support. And I think the part of this strategy that requires wider thought from our perspective is the fact that the health of the 51% should also depend on how the remaining 49% act. And the question then comes on, why is it only a woman's responsibility to have contraception? Why should there not be male contraceptions developed? So that it is a joint responsibility to support people in having the right answers. When you talk about 45% of unplanned pregnancy rates, it's shocking. And in today's awakened society, I feel equally ashamed as a man that we don't have a response to this, while the responsibility only falls on a woman every time. And I wondered what your thoughts were about that, Leslie.
Well, I'm a realist above all else, and I've done a lot of global health work as well. And so I think that it's not proven to be very successful to either introduce male contraceptive methods or to get men to take the responsibility for contraception, particularly long-acting reversible contraception. So I think we've got to empower women with the knowledge they need to protect themselves from having an unplanned or unwanted pregnancy. So I often say that the importance of contraception is that so girls and women can choose who, if, when, and where, and with whom they become pregnant, because this is an extraordinary thing women do. They create a new life. And not create it, the couple create this new life, but then they nurture this and then they deliver this. I mean, it's extraordinary achievement. And I could get very sort of political and feminist and say, and it seems that women are so good at that and need to be from an evolutionary point of view, and that they then have enormous problems because they're then penalised in the workplace for being pregnant and having maternity leave, and then their pensions are different, and there's a gender pay gap. We could talk about all of those things, and I'm sure that we should do and include those too. But I'm a realist, Mohit, and you may be a very egalitarian father of girls who've explained to them the importance of this, and of boys about how they must be responsible and have safe sex. But I'm a practical person who's been in a gynecology clinic for too long to think that I'm going to rely on men to use contraception on a regular basis.
Thank you for that. And I think it's understandable. It's widening the access for all of us to stand up and say, we stand tall and recognizing it's the right thing to do, because actually you were spot on when you said, if you do it right for women, you do it right for society. I think there's something around the role of primary care, and you alluded to it when you went and saw the hub in Liverpool, Leslie. And how did that hub function? What was different that made it really give the outcomes you were looking for?
Well, the practitioners who are working there are really empowered to be able to provide women with what they want. They've got appointment systems, and they are reimbursed, the general practitioners, that is, for the time for fitting devices, for example, for giving practical solutions. In Wythenshawe, in the unit that Asha Caslewell has put together, she was recently, you may remember, the president of the Faculty of Sexual and Reproductive Health for 2 terms, not just 1. That's an extraordinary thing, where she's an OBGYN who then went into community gynecology and has set up this community hospital whereby health practitioners and health assistants often take the histories from the women who come in with menopausal concerns or urinary incontinence or prolapse or all sorts of other things in contraception. And then they have a multidisciplinary mix of clinicians and healthcare professionals who can provide the various services. And then they have the easy recourse to the senior individuals who are, if you like, bridging the gap between primary care and secondary care, so that you don't have to keep moving the women and taking up loads of secondary care appointments. And excuse me. And interestingly, I thought that perhaps wrongly, because I'm a secondary care doctor for most of my life, I thought that the traffic was all going to go one way in terms of the knowledge base. But no, I mean, what I saw very clearly there was that the secondary care facility or practitioners or doctors or gynecologists, let's say, were actually learning enormous amounts about primary care needs because of the regular discourse they are having with the primary care colleagues. So I really do think it's a win-win, and it's something that we've really got to promote. And it's actually what women want. They want to be able to go somewhere and get things sorted out. You don't want your daughters to have to go to 4 different appointments, take 4 days off school or 4 days off work. It's just ridiculous. And I think possibly what we need to do to help us persuade people persuade our political masters to get this changed is to make the economic argument that we cannot afford at this present time, particularly now after the crises of the last couple of weeks, let alone since the Ukraine war started. We cannot afford to be wasting resource, and we cannot afford to be wasting resources of women in the workplace, because they do a massive chunk of work. And if you have a lot of menopausal women who leave work between the ages of 50 and say 65, you may be able to replace them with a body, but you don't replace them with someone with that experience and that degree of maturity and knowledge and their ability to mentor. Often younger trainees in my department will say to me, well, what do you think about this? And I think, well, actually, I think we should just do nothing and wait and see. And that takes a lot of experience. I'm sure you will say the same in your particular area of expertise. So you do need the older women to retain it. And we just can't afford to lose them from the workforce. And if we were talking, there's a couple of questions about younger women in the chat I noticed. It's absolutely shocking that about half of girls of school age now are missing school, not just because they can't manage their periods or they've got a lot of pain, but also because they can't afford period products. We cannot let this group of adolescents down and not educate them properly. I mean, we've got the largest group of adolescents in this world in history now. Our neonatal and our pediatric colleagues have done such a fantastic job, that we have got a very, very large population of adolescents. And I think we're just walking into a trap to let them all down if we don't give them the tools they need to understand about their reproductive autonomy and also their health, particularly the women.
The other ill that society is seeing often, and not always, but almost exclusively suffered by women, is about domestic abuse. And that has awful impact mentally, physically, psychologically, socially. And it does make it really hard for people to access some things because they feel they are excluded and marginalized. The creation of Women Hubs also give the opportunity to start looking at widening the access, exactly as you were saying, of not just having health professionals, but other professionals around, especially the third and the voluntary sector, so that they can create the wraparound services that are needed often. And I think it goes back to the heart of the point you were talking about. There are more people who can be trained to give support and access in the community than what we talk about being a doctor and a nurse always.
Absolutely. I mean, I meet women every day who would like to make a contribution towards improving women's health. They're not doctors, they're not teachers, they're not accountants or lawyers, but they would like to contribute something. And as I say, in some of the hubs that I visited, I've been really impressed by some of the healthcare assistants who are sitting women down or girls down and starting to get them to tell their story. They will be the ones that unpick the bit about this woman's a victim, or, you know, she's at risk of harm, because they are giving them the time and the compassion and the concern. They're not rushed off their feet trying to whiz through their appointments. So I think there's enormous scope for including a lot more members of our society into promoting this. And we will do an enormous amount for community relations as well. You mentioned about violence against women, which really has become the second pandemic, hasn't it? The silent pandemic, which has escalated during the COVID lockdown. And what I think is interesting about violence against women, or tragic, I should say, not interesting, is that unlike every other disorder or healthcare risk, this has no boundaries at all. It has no socioeconomic boundaries, no educational boundaries, no financial boundaries, no geographical boundaries. The prevalence in London is the same as in Solihull. It's the same in Mumbai. It's the same in Qatar. It's just extraordinary. So we have got to do something about this. And I was very interested by a podcast I listened to about a year ago, when I was preparing to give a talk about violence against girls and women. And this was an American, actually, who was talking, a male, who was talking about the fact that after the Sarah Everard murder last year and the Me Too movement really cranking up, there was this backlash, if you like, from some men saying it's not all men. And I was very impressed by this male talking about the fact that that was quite wrong, and that to say it's not all men is a little bit like Leslie Regan telling you that I am not racially biased. That doesn't mean that I'm denying that racial bias or discrimination exists. So you know, you can't say it's not all men. Every man and every woman has got to become part of the solution. And the solution is that we do not tolerate violence against girls or women in whatever form, and violence against men as well.
I think you're right, and I think I understand that violence against anyone is wrong, but the fact of the matter is, it is usually women, and it is not acceptable. It is just not acceptable in today's society. I think it was never acceptable. It's unfortunate that it ever happened, and today, at least with the awakening, it's time we stepped out and said this is not what will be done. I think one of the challenges, and many people have in the chat and in the QA session raised, is the challenge of accessing secondary care services with ease. And you spoke about this eloquently a little before, Leslie, even though you did just helpfully suggest that you would drop in some of the contraceptives they wanted, even if you were not allowed to prescribe it there. But of course, you and I know the waiting list for many of these specialist clinics, the menstrual clinics, is so long that it is a pity that a service that should be easily accessible is not available. Today, we have about 400 people who have registered for this, and many of them have turned up for the webinar. So if I was to ask you, Leslie, what's the one thing that will be your ask of primary care to make a difference to the outcome? What would you say that'll be?
I would say to try and crack this difficult to access contraception, because I think it would make a real difference. And I don't expect primary care to do it on their own. I expect the secondary care have got to do their bit, because although by definition, if you do offer post-delivery contraception for a year, you're already talking to a woman who's just had a baby. But by the same token, they are a captive audience. You don't have to go out and find them. They're in that labour ward or in that postnatal ward, even if it's for a few hours. And it's not difficult to put in an implant or to give them an injection or to give them a year's supply of progesterone-only pills. You know, the new desogestrel pills are extremely effective. They're just as effective as the combined one, and they're perfectly compatible with breastfeeding and have minimal side effects. So I really think that we should, I'm so struck by how contraception is so easy and yet so poorly accessed. And so poorly rated as well. Everyone thinks, oh, it's somebody else's business. And it's, as a result of it, it's nobody's business. And we've got enormous problems as a result of it. What's really important, I think, to understand about that And this is not just as a gynecologist and obstetrician speaking, but as somebody who's interested in women's health and also neonatal health, is that if you have birth spacing of 12 to 18 months, you reduce every single complication of pregnancy. Or put the other way, if you have a baby within 12 months of delivering a previous baby or having an abortion or whatever, you're going to increase your risks of prematurity, of brain, of a neonatal death and stillbirth, of every maternal complication, and particularly in maternal health complications increase dramatically. So there is every reason to try and get this right.
Thank you. And I think taking it on from a perspective of a resident to the perspective of people who work in health services, amazingly, we are a health service which has a majority of women who service the industry, and without them, I think we would be down on our knees and unable to provide the services we do to our population. Interestingly, also, among the leadership echelons, you see very few women. It's not just an ethnic bias, there is a gender bias, there is no doubt, there are more men. And it is very hard to recognize the needs of the workforce when you're not one of them. And I'll give an example of myself. I attended a webinar the other day on menopause, and I was struck by the fact that I didn't realize what a brain fog was and how it felt for years if you go through long-term, how awful the pains were and what you felt about yourself. And I came back so much more enlightened, this despite being a doctor and recognizing exactly how menopause impacts the body, but not recognizing how it impacts a person who's going through it. And that's significantly different to reading medicine. What would you think would be the one way of making a difference to how people in leadership places start recognizing the needs of the local workforce, who most often are women and deliver care?
Well, how long have we got? I think we're running out of time now, but I think there's an enormous amount that can be done. And I think that certainly in secondary care, and you will have to give me the equivalent in primary care, secondary care trust boards that invite lay people to contribute to their agenda and to be constructive critics, have been shown to have have much better outcomes in terms of their healthcare outcomes for that trust. We know that including women, and I'm going slightly off target here or off piece. We know, for example, I'm very interested by how the FTSE 100 and the FTSE 500 are built up, and there is an indisputable fact that in the FTSE 100, the board members have got much more gender diversity in them, and that you bring women to that board table and leadership role, and the tensions change and the atmosphere changes and the dialogue becomes much more inclusive. And those companies that are in the FTSE 500 are the ones that are at the bottom near the 400 or 500. Those are the ones that don't have much gender or female representation on their board. So I think you'll see the same thing. But I can't say that I've done the analysis on trust board gender split, but undoubtedly you will find that women in positions of leadership in trust boards, and I'm sure in primary care groups, bring a different dimension. And I'm not saying that men shouldn't be there, not at all, but I think we need to have both represented because we bring different skills and different talents.
I think we are on the home run. We have only 5 minutes. Any last thoughts before we start closing the evening?
No, I think I'd just like to hear from your colleagues and all the people who've bothered to tune in this evening, what I can do to make them feel included and want them to come and join me. And I'd be very happy for you to give them my email address, the Women's Health Ambassador email address, which everybody I think in the world has got now. But I really do want to hear from colleagues about best practice. I do not think that the answer is to go and impose new sets of rules and new sets of diktats onto very experienced colleagues, particularly those working in primary care, who have a real understanding of the communities they're working with and working in. I think it's really important to be inclusive and to be collaborating, for me to learn from your experience, and perhaps I can offer to help move some of the deck chairs around by shaking up a few pots of money somewhere. But I really do welcome criticism and thoughts and constructive comments about what we can do to make things better, particularly in cutting through the bureaucracy so that women can access help when they need to. And then we could just let them get on with their lives, as opposed to chasing around trying to get a Mirena coil or a cervical smear or a mammogram or a cardiovascular assessment. Why is it that women don't do nearly so well after a cardiovascular event, and they present later, they present differently, they're much less likely to get appropriate medications, etc., etc. We've got to really think about it. And I suppose I would say this, a woman of my age, I'm particularly interested in how we're going to postpone all those problems in cardiovascular disease and osteoporosis and frailty, because that's a massive, massive problem that it's so, to date, I think it's been in the too difficult box. And I think we've got to open the box, even if it is too difficult, and say, okay, we're looking at you and we've got to come up with some solutions.
Leslie, it has been such an incredible pleasure to have had you on today's event. The drive and energy that you bring clearly gives all of us the ability to support this implementation. And thank you so much for accepting that people would love to be part of this movement. So many people have shown such active participation today in the webinar. Clearly, many of them would like to be part of this. The facts you shared about life course approach for women, looking at prevention and the investment in prevention being so little, UK being the most obese in Europe, how difficult it was to access contraceptive, 45% of unplanned births, and less than 10% of people saying they have access to information are shocking. But it's such a relief that you are leading the effort now, because it does leave me feeling warm that my daughters will have a place in society that's genuinely supportive and fosters them for what they will bring to community, rather than having to fit to what society already provides. For those of you who have participated so actively today and lit the Q&A session board with so many phenomenal thoughts and questions, please do use the QR code that Sarah has put up for all of us to give some feedback. Our next event is on the 16th of November from 7 to 8 p.m. And Dr. Amanda Doyle, the National Director of Primary Care and the senior most GP in the country, will then be sharing her thoughts on what she thinks the future holds for primary care. A very, very big thank you to Dame Leslie Regan for the time she has given us today. And another thank you to the amazing Ruth and Sarah, who helped this work through and in the background have made this a reality today. Thank you to all our participants. It was great seeing you all, and I'll look forward to seeing you in the next one. Leslie, thank you again.
My very great pleasure. Thank you.